It is a pleasure to introduce my mentor, Professor Vivek Lal, who needs no introduction to the forum. He is presently heading the Department of Neurology in PGI. He is former Dean, Baba Farid University of Health Sciences, Punjab, and has been invited as a faculty and chairperson several times in World Congress of Neurology. He has been a visiting guest faculty in University of Oxford and University of Addis Ababa, Ethiopia. He is a pioneer and a distinguished figure in the field of neuro-ophthalmology. His work in ophthalmoplegic migraine is phenomenal, with the largest case series in the world. And he has more than 200 publications in various international and national journals. His qualities as a teacher and clinician are unparalleled and unmatched, which can be aptly described by this couplet of Sant Kabir. Sab dharti kagaj karun, lekhni sab ban raay, saat samundar ki masi karun, gurugun likha na jaye, which means if the whole earth is transformed into paper, with all the big trees made into pens, and if the entire water in the 7 oceans are transformed into writing ink, even then his excellence as a teacher cannot be described. Sir, over to you, sir.
Am I audible to everyone? Am I
Yes,
audible?
sir. Yes, sir. Yes, sir.
Good evening, everyone, and thank you so much for time. I'll be talking on neuro-ophthalmology of systemic diseases. We were having a temporary glitch when I was being introduced. Thank you so much, Anand, for the kind introduction. So, you see, basically what I'm going to do in the next half an hour is just tell you a few pearls of neuro-ophthalmology in 2 circumstances. A, as the disease progresses, what are the neuro-ophthalmological ramifications of the diseases that we're going to discuss? And B, how does neuro-ophthalmology herald the onset of a disease? So, as we go along, we'll see what I'm trying to tell you. So it's all important for us to remember the most important fact that we learned in MBBS, that the optic nerve is an extension of the central myelin. We all know that. Hence, any CNS disease can affect the optic nerve. We have 2 components of the visual system, the afferent and efferent. We all know what afferent does and what efferent does. But what is important to remember is that it is probably the most perfect of all systems. You know, the afferent and efferent circuits together constitute 50% of the brain parenchyma, and there is no aberration. There is no scope of any. There is no scope of any, deviation from what is normal. So it's important for us to remember that the optic nerve is an extension of the central nervous system, and whenever there is diffuse pathology, it knocks down the optic nerve. You can have all sorts of syndromes, neuro-ophthalmology and systemic disorders. You can have the orbital inflammatory syndrome. You can have the dry eye syndrome in Sjogren's, and the same syndrome, the same disease can give rise to vitritis, optic neuritis, disc edema, with or without granulomas. So typically seen in sarcoidosis, but sarcoid is not the only pathological disorder which can knock down almost every component of the visual. There are other diseases like Sjogren's disease, like vasculitis, like Wegener's, which do the same. It's just a matter of time before neuro-ophthalmological ramification will occur in an uncontrolled vasculitis. So we'll begin our discussion with endocrine disturbances and neuro-ophthalmology, which is the single commonest endocrine disturbance that you and me know. It's diabetes. Now, usually remember there was this phrase in medicine, they said that if you know what diabetes does to the body, you would probably know medicine, because diabetes wrecks every system in the body. So you know the ramifications of diabetes, you know medicine. The same holds true for diabetes and neuro-ophthalmology. If you know what diabetes does to the visual system, you know a significant amount of neuro-ophthalmology, and I mean it. So, which is the single commonest disorder relating to diabetes and the neuro-ophthalmological system? We all know you have got diabetic proliferative retinopathy, and you also have got disc edema. You also, as the disc edema progresses, it leads to what is called diabetic AION. You can occasionally have macular scarring. You can have vascular disorders of the optic nerve, NYD and NYE, neovascularization of the optic disc, and neovascularization elsewhere. These are important components of the ravages of diabetes and the optic nerve. So let's begin our case discussion with simple cases, simple, straightforward cases, but they teach us a lot. This is a patient who has come to us with a 4 days history of acute visual loss, which the patient has noticed on waking. He's a male, he's a diabetic, and he is a smoker. Now, the moment you get this kind of a history, with this kind of a background, the first thing that you should jump on is rule out AION, that is anterior ischemic optic neuropathy because of diabetes. It's important to remember that for some reason which is still not very clear, an overwhelming majority of ischemic damage to the optic nerve occurs on waking up. Now, one of the hypotheses which has been put forward is that you get a dip in blood pressure when you are sleeping. Now, when you are sleeping, that further damages the vulnerable optic nerve apparatus in diabetes. So a further decrement in blood pressure leads to thrombus formation at the level of the posterior ciliary arteries, giving rise to AION. What is important is an important fact which I am highlighting here. Often there is a past history of visual loss in the opposite eye, but when you have got NAION, that is non-arthritic AION, there is a gap between one eye and the other eye. In arthritic AION, the other eye is going to be involved in less than a week. Here it is often months to a few years. So that's the importance of NAION here, but it does not mean that you ignore a visual loss in diabetes, because that is a clarion call. You need to do coronary artery coronary artery imaging. You need to have a look at the vascular tree in the brain, etc., etc. Now, what is the hallmark of the disc in diabetic AION? Anterior ischemic optic neuropathy classically is characterized by an altitudinal field effect. Notice the altitudinal field effect, inferior altitudinal hemianopia, and disc edema along with flame-shaped hemorrhages. I repeat, don't miss the altitudinal field effect. In my life in 30 years, I have not seen altitudinal field effect in any other disorder of the optic nerve other than AION. I repeat. So if you are making a diagnosis of demyelination and demyelination and papillitis, and the visual field is showing you a classical altitudinal field effect, you are probably on the wrong track. You are on the wrong track. In all probability, it's a vascular insult. The other important thing to remember is these flame-shaped hemorrhages classically occur in diabetes and AION. They do not occur in demyelination. They do not occur in papillitis. They are seen floridly in papilledema, but they are absent in papillitis. Also notice that the opposite eye, which was involved 3 years ago, already has got optic atrophy. Now, what is important is when you do a visual, fluorescein angiogram, you will notice a significant filling defect. That's important. Notice the filling defect. One half of the disc is filling, the other half is pale. And this is very typically seen in AION because of diabetes, hypertension, or other vasculitis. But when you have a granulomatous angiitis of the nervous system causing AION, You will also have choroidal filling defects. Look here that the choroid is not involved here. You are getting to see hemorrhages, which are obviously visible here, but the underlying choroid does not show any. Now, the other important component of diabetes and neuro-ophthalmology happens to be diabetic ophthalmoplegia. You all know diabetic ophthalmoplegia. You all know what it presents with. You all know what to do. What I am going to tell you now in the next 1 minute is one very important clinical pearl. Note that down in your diary. 40% of patients of diabetic ophthalmoplegia are the presenting symptoms of diabetes. Remember, I began my lecture by saying that neuro-ophthalmology in systemic disease is of two types. A, that type which will manifest as the disease progresses, and B, which heralds the onset of the disease. Diabetic ophthalmoplegia in 40% of the cases will herald the onset of diabetes. So if a patient comes to you with an unexplained third nerve palsy with pupil sparing, I'm making that point, and denies a past history of diabetes, please go ahead and get a blood sugar done, as I will show you in the next two cases. The other important fact to remember in diabetic ophthalmoplegia is there is one nerve which is involved at a time. You can have either the third or the sixth or the fourth. It is often painful and pupillary sparing is seen in 80% of the cases. Meaning thereby, suppose you are having a diabetic, I repeat, the patient is a diabetic but comes to you with third and sixth nerve involvement simultaneously, it is not diabetic ophthalmoplegia. It is mucor. This is ophthalmoplegia in a diabetic. I hope I am clear. Diabetic ophthalmoplegia means the patient is a diabetic and the cause of ophthalmoplegia is diabetes. Whereas ophthalmoplegia in a diabetic means that the patient is a diabetic but has got ophthalmoplegia because of other reasons. You can have fungus, you can have TBM, you can have all sorts of different, diseases. So any lesion or any, lesion which knocks down, in a diabetic, which knocks down the, nerves will often have a combination of more than one nerve. And the moment you have more than one nerve involved simultaneously, it is not diabetic ophthalmoplegia. The prognosis is good. You do a GAD enhanced MRI, and the reason I do a GAD enhanced MRI is I just want to exclude, mucor and infections. Although the American Academy of Ophthalmology says that you need not do an MRI, I would probably play safe. Now, one of the most important images that we have learned since our MBBS teaching is why does a PCOM aneurysm pick up the pupil and why does diabetes spare the pupil? Have a look at diabetic ophthalmoplegia. We all know that in a third nerve, the pupil fibers are lying in the periphery. Diabetic ophthalmoplegia is because of involvement of the vasa nervosa supplying the third nerve. Now the vasa nervosa, when they supply the third nerve, they penetrate from outside. So when there is damage to these vasa nervosa, you are going to have watershed infarction, and this watershed infarction is going to occur in the center of the third nerve, meaning thereby that the peripherally situated pupillary fibers are spared. That is why you get pupil sparing third nerve palsy. Whereas in posterior communicating artery aneurysms, there is an outpouching of the posterior communicating artery, and that picks up the pupillary fibers first of all. So you will have ophthalmoplegia with pupillary dysfunction. So you have to distinguish between a surgical ophthalmoplegia and a medical ophthalmoplegia. 20% of diabetics will have some amount of pupillary involvement, but they probably never have a full-blown pupil like is evident in this case. So this is a patient who actually had loss of weight and appetite. Rohit, if you remember, you probably won't remember this case. So this is a patient who came with loss of weight and loss of appetite and had a third nerve palsy where the pupil was spared. You notice that the pupil is spared. He had just an isolated third nerve palsy. Notice the sixth nerve is not involved, but the third nerve is involved. There is impaired medial rectus, superior rectus, and inferior rectus movement. Lateral rectus is normal. The fourth nerve was also normal. The pupil was spared. He denied any past history of diabetes. I repeat, he denied any past history of diabetes. We got a GAD enhanced MRI. It was normal. There was nothing fishy in the GAD enhanced MRI. We did a CSF, which was normal. Again, there was nothing fishy in the CSF. And then what happened? By chance, we picked up that this man is having a hemoglobin A1C of around 9. Right? And he then came back and said 3 years ago he was diagnosed as a diabetic and that he had taken Karela juice and things like that. And after that, he's never got his blood sugar again. So now this patient turned out to be having diabetic ophthalmoplegia, one nerve at a time, normal MRI, normal CSF, normal works, and we just gave him painkillers. I repeat, painkillers, neurotropic painkillers, and he made a complete recovery. That's important for you to remember that recovery is the rule. If a diabetic ophthalmoplegia is progressing in spite of your best efforts, please look for a malignancy. Please look for something else which is lurking in the background. Now, what are the things which can lurk in the background? A PCOM aneurysm is a very common masquerade in a diabetic ophthalmoplegia because they often tend to be hypertensive also and they tend to be diabetic. Some amount of pupillary involvement can often be missed. So it is always worthwhile to do a good MR angiogram in these patients to make sure that you have also excluded a PCOM aneurysm, although the gold standard is a DSA. Either you have a good neuroradiologist with whom you have a good rapport, who knows how to pick up the PCOM, who knows how to look at the posterior communicating artery aneurysm, or you do a DSA. We have got both. I often depend upon a good MR angiogram until it is absolutely necessary for me to get a DSA, because I would not go for a DSA just like that. I would go for an MR angiogram. I would request the radiologist to please zoom the posterior circle, the circle of Willis. I would request him to direct his attention at the posterior communicating artery. Now, what are the other endocrine disorders which can affect the nerves and the muscles? You all know we have thyrotoxicosis and you have Graves' ophthalmopathy. Now, look at this. This is that famous slogan, I am slow. What is I? I stands for inferior rectus, M stands for medial rectus, S stands for superior rectus. The other I is involved. Then as time goes by, the patient's condition worsens. The patient gets complete fluoride involvement in one orbit and has got fluoride involvement in the other orbit. But again, this is following the same pattern. I am slow. The lateral rectus is still to be picked up here, although it has been picked up in the eye where all the mischief began. And it's important for us to remember that thyroid ophthalmopathy is an emergency because they can lose vision. That's important. Because of pressure on the optic nerve, the intraorbital pressure goes up, they lose vision, hence they have to be given emergent thyrotoxicosis treatment. We all know that steroids, we all know that these patients need to be given high dose neomercazole so that you can knock down the Graves' disease. But it is also important to remember one important aspect, that you can have thyroid eye disease which is not commensurate with the thyrotoxicosis, meaning thereby there can be a dichotomy between the two. So this is another patient again, known hyperthyroid on treatment, diplopia of 2 months duration. The patient had not got, was not on regular follow-up. She suddenly came with diplopia, and then we noticed that she's got eye signs. And when we got the MRI done, we picked up the superior rectus thickening. Now, this was how this patient presented as a relapse. She thought she was okay. She was going around. And then she had diplopia, and then notice very carefully, she's also got swelling of the upper eyelid, and she's got this redness, rubor. And when we did the cause, there is retraction of the upper eyelid also. Notice very carefully, there is retraction and there is puckering of the upper eyelid, and we got the cause here. This is thyrotoxicosis relapse. But it's also important to remember that alone thyrotoxicosis, can also give rise to what is called bilateral ptosis. Then in that case, you won't call it exophthalmos. Exophthalmos is proptosis, and retraction of the eyelid. Whereas here you are having a patient of thyrotoxicosis proven who has come with bilateral ptosis. And the moment you are having bilateral ptosis in a patient who's got a hyperthyroidism, the first thing that you exclude is do a neostigmine test and you rule out myasthenia gravis. So that's important. This patient had anti-TPO antibodies which were positive and acetylcholine receptor antibodies which were positive. It's very well known that thyrotoxicosis and myasthenia gravis can coexist with each other. So please remember the associations as we go along. Now, having discussed endocrine diseases, it was a very brief introduction. We've talked about diabetes. We have talked about thyroid. These are the two most common endocrine anomalies knocking down the visual system. We will now go to tumors. And what is the tumor that you and me often get to see, which actually has a major role to play in visual morbidity? That is, in causing visual morbidity, it's a pituitary adenoma. We all know since our MBBS days that you can have visual loss in adenomas, and the visual loss can be painless. I repeat, painless. I'm not talking of painful visual loss. Often visual loss in adenomas can be painless and can give rise to primary optic atrophy without causing raised ICP. Notice that this patient has got visual loss. Right eye, temporal pallor. Left eye, probably the disc is paler as compared to the right eye, but the margins are very clear. So this is bilateral optic atrophy, left more than right, and the cause is evident here. There is an adenoma, and this adenoma has gone out of this, pituitary fossa, out of the sella turcica, and is knocking down the chiasm, and it is causing what we all know as chiasmic infiltration and chiasmic compression. And it is also giving rise to a bitemporal hemianopia, which is characteristically seen with these disorders because it impinges upon the crossing fibers from below, and that's how it is. What I want to tell you is this is chronic visual loss, progressive visual loss, and so you will get an MRI done thinking that it is Leber's, and you might land up seeing an adenoma. When you get acute visual loss because of severe bursting headache in the emergency, you have to suspect pituitary apoplexy. Please get a CT scan done and please get an MRI done. But important thing to remember is kindly tell your radiologist to concentrate on the sella. I mean, you have to tell a radiologist what you want and expect out of it. Tell him to concentrate on the sella and tell him to have a good look at the sella, because if he misses, you are not going to pick it up. Be very clear. You have other things to do in the emergency. That's important. Here is another patient, female patient, who came with severe visual loss and which was acute in onset. Now, it's important to remember that apoplexy can often be the first presentation of an adenoma and can be the presenting symptom of an adenoma in more than 1/3 of the patients. And what are the conditions where an apoplexy can occur? It can occur in diabetes. It can occur in patients who are anticoagulants, patients who are pregnant, and in patients who have got recent weight gain. And the other important factor which often induces apoplexy is if these patients are hypertensive. For some reason, apoplexy has a higher incidence of occurrence in these patients. It can knock down the optic nerve. It can also spread sideways and can knock down the structures of the cavernous sinus. It's important for us to remember that apoplexy is an emergency. The moment you suspect an apoplexy, please remember the first thing that you do is after you have the CT scan is put on treatment. That's IV steroids. That's important. You have to resuscitate the patient. They often are in shock and the rest will follow. You don't have to waste time waiting for all investigations to come. I repeat, in India, it will take more than 24 hours to have everything on a plate. Those 24 hours are life and death for a patient. Start the treatment, please, and then let the investigations come. I know there will be a group of doctors who will say, no, we don't want to be unscientific, which is fine. But I cannot believe that practicing science at the cost of a patient's health is appropriate science. That's not fair. Either you have everything in 1 hour, that's okay. But if you're going to have everything in 6, 7, 8 hours, time is the essence. You are making a patient lose vision. The patient will continue to be where he is, and lack of commitment on your part will be responsible for the visual morbidity the patient suffers later on. Then there are hypertensive patients. We are talking about vascular disorders. We are now coming to vascular system and disorders. We'll discuss 3 things. I have got, I think, 10 minutes more. I'll finish off everything in 10 minutes. This is hypertensive retinopathy. What is important is you seeing some amount of disc edema, you seeing hemorrhages, you seeing all these things here and there. These are soft exudates, retinal, cotton wool spots, and the patient also had got. This is very typically seen in hypertensive, encephalopathy, classically in pregnancy, postpartum state, and in uncontrolled hypertension. What is important now here is, at times you can have hemorrhages in press. So just because you have got an hemorrhage doesn't mean that this patient has got a granulomatous meningitis of the nervous system. So you kind of go and do an angiogram where you will pick up some bleeding and think it's granulomatous meningitis and put him on immunosuppressants. No, sir, no. This is hypertension. This is hypertensive retinopathy, and this, my lordship, is press, right? And this hemorrhage is something which is known to occur in press. You put these patients on antihypertensive treatment, they recover completely with or without diuretics. There's another patient, again the same story, having involvement of the optic nerve with hemorrhages and having occipital damage, right? I have seen more than, I think, I would have seen 50 presses, 50 patients of press in the last 10 years. That's a low underestimate. Almost all recover. I have never seen a complication with press, probably because the manifestation is so dramatic that it is picked up fast and treatment has an effect. Now, what is the treatment? You lower the blood pressure. I give steroids. Many say there's no point giving steroids. Steroids are harmful. While you can debate all that, all I can say is I have seen miracles with steroids in press. So I'll go by what I see. You can go by what you see and what you hear and what you read. But I'm telling you what I have seen. I see that the moment you give them steroids, from no PL, no PR, they are back to normal vision, 6/6, end of 7 days. That's only if you give them steroids, right? Here's another patient. This is an ocular ischemic syndrome because of hypertension. The patient has got, Rohit Bhatia would be interested, complete stenosis here and is gradually progressive stenosis. So when you're having gradually progressive stenosis, what happens is there is collateralization of the orbit. There is a ischemia of the orbit, and so you will get what is called ocular ischemic syndrome, giving rise to neovascularization inside the orbit and inside the retina. You're seeing a disc which is all totally, massacred by the ocular ischemic syndrome. There are multiple hemorrhages. You can see attenuation of blood vessels here. This is not what normal blood vessels look like. Veins and arteries are attenuated. They are thread-like. And you are also seeing a lot of retinal edema and pallor. This is very typically seen in ocular ischemic syndrome. If you do an intraocular pressure in these patients, it is often low, but they can have glaucoma also because of neovascularization. So we come to metabolic diseases. Then we are going through, we are kind of ripping through these diseases because of the shortage of time. We started with endocrine diseases. We talked of tumors. We had discussed vascular diseases, and now we come to metabolic diseases. Now, I must tell you one thing. As I told you, 50% of the brain is devoted to vision. So obviously, then there is a chance that the visual apparatus is going to be picked up in almost anything that knocks the brain down. So have a look at this. This is one of the first patients I saw, a metabolic disorder. I had a radiologist son who came to me when I was an assistant professor. The radiologist was in psychiatry, and he noticed that his son is becoming aggressive, right? And when a psychiatrist sees that his son is becoming aggressive, you would say that the psychiatrist is oversensitive. But for some reason, this patient's aggression was worsening, and it became so severe that he had to be put on antipsychotics. He continued to have worsening of features. That is when they first came to me. I repeat, when he came to me, there was no CT scan, nothing. I noticed this KF ring. And that's when I got this MRI done. So this means this would have been after 2000. And I picked up these basal ganglia hyperintensities, and the rest automatically followed. We put him on penicillamine. At that time, penicillamine was given in very low doses, and he recovered significantly. But as often happens, unfortunately, he discontinued his medical therapy and he came back with dystonia and Parkinsonism. I don't know what happened to him after that. I think they went to England. I don't know what happened after that. So that's the story of this young, bright child who came to me on antipsychotics, and he turned out to be having Wilson's disease. So one needs to remember all these things when we are discussing. Then there are eye signs in hepatic cirrhosis also independent of Wilson's disease. I don't know whether you remember Hutchinson's textbook. Hutchinson's textbook talked of exophthalmos in cirrhosis. Hutchinson's textbook talked of exophthalmos in congestive heart failure. Now here is a patient who's got proven cirrhosis and has got this syndrome which Hutchinson described in his textbook, which we used to read in Final Prof in MBBS. I have not had the, I must honestly confess, when you go to see a cirrhotic patient, you generally don't concentrate on the eyes. There are other things to look at, but these are some well-known eye signs in cirrhosis. Uremia is another condition which can cause uremic optic neuropathy, but then uremic optic neuropathy often is considered a form of AION. Now, finally, I'll bring up these rheumatological disorders. There are two important things to remember in rheumatology. Please remember, there is no vasculitis which causes optic nerve involvement before it causes peripheral nerve involvement. Almost all vasculitis will first cause a wrist drop, will first cause a foot drop, and then will cause a optic nerve damage, except granulomatous uveitis of the nervous system or temporal arteritis. I repeat, temporal arteritis and granulomatous uveitis are the only two vasculitis which pick up the CNS before they pick up the PNS. 77-year-old female comes to you with headache and jaw pain, severe headache and jaw pain, sudden loss of vision in both the eyes. The ESR is 80, the CRP is positive. It's a no-brainer that you are looking at temporal arteritis with choroidal infarcts. The patient has already got optic atrophy. This is pale disc edema with optic atrophy in the left eye and pale disc edema with optic atrophy in the right eye. And what you are seeing is there is attenuation of the optic nerve already. So savage is the insult to the optic nerve by granulomatous uveitis of the nervous system, by temporal arteritis, that I meant temporal arteritis, that you can get optic atrophy within 3 days. Within 3 days of the insult. So that's how savage the insult is, right? When you do a biopsy, you pick up what you need to see. There is destruction of the internal elastic lamina, and there is extensive vasculitic infiltrate with lymphocytes. There is, medial thickening and things like that. There is extravasation of RBCs in the tunica media. A classic case of temporal arteritis, but you may not get this. You get a patient who has what is there here, but has an ESR which is raised and CRP is positive. Start the patient on steroids. Don't wait for the biopsy. The ENT surgeon will come and do the biopsy on his own. Put the patient on treatment. You will save one eye. Then there are ischemic optic neuropathies other than, giant cell arteritis, other than temporal arteritis, and other than, hypertension and diabetes. I have seen ischemic optic neuropathies in patients of Behçet's syndrome. I have seen ischemic optic neuropathies in patients who have taken Viagra. And I've also seen ischemic optic neuropathy in migraine. A lot of ischemic optic neuropathies which come to me actually have migraine. This is a patient who had Wegener's, and this is how it is: gangrene here, you're seeing a pseudotumor here, and you're seeing a depressed bridge of the nose, and you're seeing a clear-cut hypopyon here. All this is what Wegener's can do. The patient had a past history of foot drop and a wrist drop, as I was pointing out, and had gangrene. This is Wegener's, right? You do a biopsy, nasopharyngeal biopsy, you get granulomas, Wegener's granulomas, which all of you know are hard to treat. Lupus also does the same thing, but again I'm telling you, please remember, lupus, young female, foot drop. Lupus, young female, wrist drop. Then comes optic neuritis. So if a patient comes to you with optic neuritis, straight away, what do you think is optic neuritis? It is demyelinating. You must investigate for a vasculitis, but don't get carried away. Don't change the trajectory of your thinking. Remember, first things first. Common things are more common. Lupus, foot drop. Lupus, wrist drop. Lupus, CNS lupus, seizures. Lupus, chorea. If a patient of lupus has optic neuropathy at the onset of the illness, be very careful. It might be something else. It might be a masquerade. It might be a lymphoma, a primary CNS lymphoma, where an occasional ANA may have come out to be positive, and the referring physician would have said, oh, this is lupus, so you go to a higher center. It might be a primary CNS lymphoma causing optic nerve involvement. So what's this? And this is what I was talking of. I think this is Behçet's syndrome. Notice you have got multiple hemorrhages, attenuation of blood vessels, disc edema, and this is a frosted branch appearance. Astha was telling me this is a frosted branch appearance. She knows better than I do that what a frosted branch appearance tells you is that there is a sausage-like beading of the blood vessels of the eye, which are continuously leaking, commonly involve the veins, the arteries are attenuated and can occur in any vasculitis. So it's not specific for Behçet's, right? And they also occasionally have, you know, if you're lucky, you'll pick up these mouth ulcers, and you will have, you'll have an HLA, which is the HLA-B5, which is positive in these patients. The largest series of Behçet's, if I'm not wrong, in the whole world is by a gentleman called Akil Siva. Akil Siva is a Turkish neurologist. Yeah, that's right. I met him in Egypt, in Cairo, and he gave a beautiful lecture, and I had asked him to come here. He was willing to come here, but then this COVID business has thrown everything out of gear. So the next time when he comes, he's going to speak for 1 hour on, Behçet's, right? Treatment, we all know better than I do how to handle these patients. What is important is it can knock down almost every level of the visual system. We have sarcoidosis. You know better than I do how sarcoid can present. Optic neuropathy, seventh nerve involvement, sarcoid granules, pachymeningitis. Rohit has reported pachymeningitis from PGI Chandigarh before he ditched us and went to All India Institute of Medical Sciences. And when you get, when you do the bronchoscopy, you picked up these inflammatory granulomas, right? And it's important that it's a diagnosis of exclusion, but you have to have a high index of suspicion to suggest and suspect sarcoidosis. Otherwise, you'll end up missing, right? And you can get bilateral lacrimal gland enlargement, very typically seen in sarcoidosis, considered a forme fruste of orbital pseudotumor syndrome. This is a patient of periarteritis, again, can occur either independently, optic neuritis. I'm forgetting what's this patient. Yeah, that's right. This is Chitrakshi. Notice she's got redness of the eye, right? There is lid edema and she has got ptosis, right? Notice that this is not a third nerve, because a third nerve does not produce lid swelling. A third nerve does not cause lid edema. This is classically a patient who has got an orbital pseudotumor. You do a, orbital biopsy, fat suppressed images, contrast enhancing optic perineuritis. This is idiopathic orbital inflammation. You're noticing that the optic nerve parenchyma is not involved and the surrounding area is involved. And the treatment is steroids and other immunosuppressants. We will finally, call it curtains, telling you that this is a toxic optic neuropathy, very common. We all know basal ganglia are involved in, methyl alcohol poisoning. 48-year-old male, bilateral visual loss, right? He had been drinking one day before with his relatives. He thought, it's English wine. Actually, it was country-made liquor. And by the time he came to us, his basal ganglia had melted away and he had got optic atrophy. Now, this is a MCQ. Optic atrophy is the fastest to occur in methyl alcohol poisoning. Please remember. In papillitis, it will take you a week to 2 weeks, not even a week to 2 weeks, let's say a month. In papilledema, it is going to take 6 weeks. Whereas in methyl alcohol poisoning. I have personally seen a white disc in 24 hours after the patient was blind. So it is Saturday night. He is drinking with his friends. I am on duty Sunday night. He loses vision on Saturday night itself. He comes to PGI. On Sunday night when I am on duty, he's got white optic disc. So in 24 hours, he's lost his vision. Another patient, this is another patient, bilateral loss of vision. This is another cannabis abuser, and we thought it is cannabis optic neuropathy. It turned out to be SSP, liquefactive necrosis of the retina. So why I'm showing both of you together is both are actually toxic. Here, toxin was the cause, methyl alcohol. Here, this man was on cannabis and he had been increasing his intake of cannabis. And so we thought we're looking at something which is cannabis related. But the giveaway was this patient had macular scarring. Now, macular scarring does not occur. Cannabis produces a vasculitis. We all know what happened to Diego Maradona, right? Right. It produces vascular involvement. Macular sparing is something which does not occur. Macular scarring, I'm sorry, is something. There's macular scarring. There is redness here. There is edema here. That was a giveaway that you are looking at something else, right? This is a zoom image of that. Notice that there is scarring, right? And there is puckering of the retina, and there are small hemorrhages, right? There was something in the occipital lobe, and so when we got the titer of anti-measles antibody, it was positive. I will, well, that's okay. That's TBM. You don't need any medals for getting it correctly. And what is important is, as I always point out, if you have a patient of tubercular meningitis, please don't give ethambutol. Because if you give ethambutol, you're not sure whether it is the drug or the disease which led to the optic nerve damage, right? Optochiasmatic or retinitis, you give steroids, generally they don't do well. It's a sad story, but that's how it is. This is post-dengue maculopathy. That itself is a topic in itself. Discussed in the World Congress in Dubai last year by Dan Milia from Singapore. Dengue positive has got a post or para-infectious dengue maculopathy. Malignancies can also at times cause problems. We have seen them. This is an NMO positive breast carcinoma. The patient had visual loss. The patient had myelitis, and the patient turned out to be having a breast cancer. So this was a paraneoplastic NMO. Another patient, similar patient, different story, different, pathology. This lady came with, as I was telling you, positive anti-nuclear antibodies, 3+. As I told you that sometimes you get a referral and your trajectory of thinking goes in the other direction. ANA was 3+. This patient had headache, and so because this patient had ANA for 3+, we thought we were looking at a mixed connective tissue disorder. Rightly so, the patient had rashes and recurrent arthritis. The patient then went on to lose vision, right? Anyone would say that this is lupus optic neuritis, lupus papillitis, arthritic AION, because this patient had all the hallmarks of lupus, which is fine. This was the optic nerve fundus examination. Notice very carefully, the patient was having florid hemorrhages which were surrounding and garlanding the fundus. The patient had optic disc which was pale, but which was edematous, and there was some amount of inflammation and swelling of the papillomacular bundle. Now that's the papillomacular bundle. Notice this, and that's the papillomacular bundle here, right? When we did the MRI, you saw thickened optic nerves. They were tortuous. The rest of the orbit was normal. The patient developed a foot drop in hospital, and when we did an MRI of the spine to see the foot drop, we saw intense contrast enhancement. We did the CSF, and that was positive for a pineal blastoma. This patient actually had a pineal blastoma, and that had led to drop metastasis, and all this was actually a red herring. This patient actually clearly had a pineal blastoma. We all know that atrial myxomas, pineal blastomas can at times produce a connective tissue disorder-like picture. So that's important for us to remember, that you don't get this kind of hemorrhages in AION. When you're getting so many hemorrhages, This clearly was suggestive of an infiltrative optic neuropathy, and the proof of a pudding is in its eating. The optic nerves were thickened and tortuous. This is not a normal optic nerve. This is a thickened sausage-like optic nerve. That's because of infiltration of the optic nerve by the tumor cells. I think I end here. I will not go beyond this. Thank you so much. And there's one last slide. I have 1 minute. So this a consultant neurology gets a call for brain death certification. This happened in PGIMER Chandigarh. Someone like Vishnu must have been there at the emergency, and he sent a call to a neurologist. I mean, imagine Vishnu is not a neurologist at that time. He sends a call for brain death certification. He examined the patient. Our consultant was conscious enough to examine the patient, that the patient is unconscious, but the pupils are not reactive, and the patient has quadriparesis. Right. Okay. So we take the history again. I mean, the consultant takes the history again, and notice the boy has been found unconscious in the morning. So it's a call for brain death certification. We have a robust organ transplant program. And so that is why this patient was, kind of referred to a neurologist who came and got this history. We carefully examined the patient, and we found only eyebrow movements. Now, sometimes what happens, when you're having complete ophthalmoplegia, it can masquerade loss of consciousness, right? Now, this is not how he was. He was worse than this, and there was some movement, and we got the cause. He actually had been bitten by a crate. He was given anti-snake venom, and he improved dramatically. I think, thank you so much for your audience, for your attendance. God bless you all. Thank you.